Started on time so we can leave plenty at the end for Dr. Bertelson's questions. But we're here today mainly because Dr. Bertelson, who is the expert on dementia care, he's a neurologist, but his field of expertise is dementia, where his professorship at Dell Medical and at Texas Tech is only in the field of dementia. He is that specialized. So he's the one that everyone comes to determine what type of dementia, what type of treatment for this disease, because neurology is a broad field, and when people take care of all the pieces of neurology, they can't necessarily be the expert in one area. So he's renowned all over, and we're awfully glad to have him back again. He started as an engineer, but decided there weren't enough people in that, so became a doctor, and has 3 out of the house. Well, one came back, but they always do. One comes back for a little while to get settled and is going out again, so he will soon be empty nester with his wife, and we're awfully glad to have him here, because the first time he came, he was pressed up against a flight and gave his talk and then didn't get an adequate amount of time to answer all your questions. So we cut a deal where I would do a little bit of presentation today, won't be long, and then hand it over to Dr. Bertelson with no prepared agenda other than to just answer your questions and go where you want to go to get answers to what's on your mind. So let me see how this works. I don't usually use a PC. And what we're going to talk about briefly is just cover some of the normal aging versus dementia. And the reason I wanted to cover this first is the people that worry about dementia the most that I've seen in my decades of nursing are the people that don't have dementia. The smart people who have normal aging, and every time they do something, they're like, oh gosh, head me to the unit. So I want to kind of settle people in their minds to have some kind of concept of what is normal aging versus signs of dementia. And along the path, there may be many of us here that are diagnosed with what is called mild cognitive impairment, which means your cognition is a little bit below what a person at your age with your education would have. But it doesn't mean you have dementia, because you're still functioning, you're living your life independently, you don't need someone to step in and care for you. And so you may hear that term and think it's a quick slide down when it is not. There are some controllable risk factors, and we'll go over a few of those. But the main thing is to have you understand. I have a little chart, but it's on the next line. I'm not going to show it to you yet. It is, what I would like you to do is use your fingers and count. I'm going to read off 7 items, and for every item that I share with you, I want you to put a finger up if you think it is indicative of upcoming dementia versus normal aging. So I'm going to go through those real quick. First one is temporarily forgetting names of people or where you left your keys. Would that be a sign of possible indication of dementia? If so, put up one finger, because we're going to be counting. We're going to see who gets it right. Forgetting the day of the week or why you entered a room. Put another finger up if you think that is a sign of dementia. The third one, making a mistake balancing your checkbook. If you think it's a sign of impending dementia, put up finger number 3. sometimes needing assistance with electronic devices. If you think that is a sign of impending dementia, add another finger. Occasionally struggling to find the right word. Do you need to put another finger up? Don't lose count of your fingers. Making questionable decisions at times. Another finger up? No. And the last one is fatigued by all your obligations or irritable whenever your routine changes. Would that be a sign, an indication of dementia? So I'm going to ask you to raise your hand. How many have 7 fingers up? You do? You have 10 up. Oh my goodness. I think someone's a worrywart. How about six fingers up? You have 6 fingers up, you have 6 fingers. Raise your hand high so people won't be afraid to raise their hand. How about 5? 4, 3, 2, 1. None. You're right. There's a handout that's going to go around. All of the things that were listed are just part of normal aging. And so possible indications of dementia are when you can't remember names of people that you know. You don't know what your wife or husband's name is, or your child or your grandchild. When you get lost on your own street and you don't even know how to get home anymore. Those are indications that you're not able to function in your normal life. When you're unable to complete familiar tasks like balancing a checkbook or following a recipe, which people may not know anything about that anymore. Since we're here and we get fed, but could you go back to a recipe and follow it and actually make a meal? Needing assistance with brushing your teeth or getting dressed, using your phone, completing sentences. When you're giving to every solicitor that calls you, you're giving every one of them money, it's an indication of dementia, or becoming withdrawn and disinterested. So Hank has some, it's a 3-page for the slides that were too small for you to read. I know what that's like. So he will have those to be passed out. It'll cover all of this, some normal aging versus possible dementia. All right. I wish I had my Mac here. This is, if you can look at the brains, this is one thing that Dr. Bertelson went back to school after he was a practicing dementia neurologist. He went back to school to go through the training that radiologists go through so that he would not be dependent on other radiologists to read his scans, that he would understand by looking at this what type of dementia it is and what needs to happen with this individual. So the brain on the left is normal, and then the one on the right you can see is different. It has some areas that are dark that are not receiving the circulation that they need. Normal brains always shrink over time. So our brains are less than they used to be in volume and size. But he's the expert on going through that and figuring it out. These are some of the things that can help control dementia. Things like diabetes, high blood pressure, obesity, and smoking. And what they have in common is all of these 4 things decrease your circulation, like You know, if your feet get really cold and they're blue sometimes, you're not getting good circulation, or you have cardiac problems, you need to get blood all over the body, and the brain is part of your body. So anything you can do to keep your circulation going will help your brain as well as your body. But there's another category, things like depression, low mental activity, or little to no physical activity. So it's one of the great advantages of a place like Westminster is you have to walk, especially the Preston right now, you have to walk a long way to get food. So it's increasing your physical activity. We're all squinched into restaurants, so you're having a lot more dialogue with people that you may not even know. That gives you more mental activity. And depression really is something that can happen, clinical depression that happens at your age. And you need to not be afraid to treat it, because untreated, it gets you closer to dementia. So these are some of the things. I think Dr. Bertelson will probably come up with more than that. But we're going to turn this over to him to answer whatever questions you want or fill in the blanks, because we all hear about dementia, but dementia is not even a diagnosis. Dementia is when people can't function in their ordinary lives and live independently. It's just an umbrella term. And there are many kinds of dementias caused by different diagnoses. So I'm going to turn it over to Dr. Bertelson. You have him as long as you need.
Okay.
Oh, and afterwards, we're going to have, when he does a little talk of whatever he's going to talk about, for the questions, will you wait till I can run over and give you a mic? Because probably the questions you're going to ask, someone else wants to know the same thing. And I want it to be heard. So I'll go as fast as I can in getting the mic to anyone that has a question.
All right, thank you, Debbie. So I didn't realize that she promised me as long as you all want. So we'll see about that. But it was an honor to be back, and I recognize some faces out there that I know, and won't say who, of course. Speak up. Is this any better?
Yeah.
All right, good, thanks. I see some fingers up. The right fingers up, so good. So thanks, Debbie. I'm a little bit out of my element not having slides to go over, but that's okay. We can wing it. I might fill in some gaps a little bit from what was discussed earlier before we pass the microphone around. I agree with Debbie that dementia and normal aging and mild cognitive impairment are all very different things. Dementia is a symptom of a disease. Mild cognitive impairment is a symptom of a disease. Normal aging is no disease. And a lot of things cause MCI, that's mild cognitive impairment. The same things cause dementia. And as Debbie said, the major difference between MCI and dementia is whether or not we start losing regular functions. Not do we lose our keys every now and then, not do we struggle to find our car in a gigantic parking lot every now and then. It's getting lost driving to places that we know. It's missing bills regularly, missing medications regularly. These are all worrisome signs that someone may be developing something beyond normal aging. Things that can cause dementia and MCI, you've probably heard of a lot of these. There's Alzheimer's disease, of course, the number one, the most common cause of dementia out there. Diseases that you've heard of through actors and famous people. Anyone want to volunteer what famous actor had Lewy body disease? Yeah, Robin Williams, that's right, good. Aphasia. Bruce Willis, right, Bruce Willis had and I didn't see these people, so I'm not disclosing anything private. He probably has frontotemporal dementia, presenting initially with aphasia. I think Janet Reno had Parkinson's disease. So a lot of famous people out there have had, Muhammad Ali had Parkinson's disease, very possibly due to having had recurrent head injuries. So neurologic disease, degenerative diseases are really very, very common. We see most of those in our clinic, and it's really an honor to be able to work at UT and at Tech to see people with these conditions. So, I don't know, that's all I really have right now. If we want to take some questions, and that might spur ongoing filling in some blanks and things, but Debbie promised plenty of time for questions, and so I'm happy to take some. We've got one right down here.
I understand that Trump is cutting off funds for research. Is that true? What will that mean?
Yeah, so reading the newspaper and hearing in the news, there are, it seems pretty widespread that there are ongoing and developing cuts to research. How studies and grants often go is that people apply for a grant for, say, $1 million, and they get extra money for what we call indirect costs. And those go to paying for staff and utilities and sort of extra stuff that the universities need. And sometimes that indirect cost is as much as 50–60% of the initial grant. And I don't live on grants at all, so I fortunately don't have to pay too much attention to that directly. But I think they're talking about cutting those down to maybe 10–15%. And so that's going to hurt a lot of studies. And people are getting let go in NIH and other government entities. So I worry. You know, I don't want to get political here, but you do worry. And the newspapers say that when people are interviewed, that they worry about setbacks and delaying new medical breakthroughs and whatnot. So it is a problem that a lot of people in the science field worry about.
Can you talk a little bit about the newer drugs that are being used right now and how effective they are?
Yeah, sure. So for 20 plus years, we had 3 or 4 pretty weak drugs to treat people with dementia, specifically Alzheimer's disease. Exelon patch, Aricept pill, donepezil pill, Memantine, and Namenda. Been around for a long time. And they help with symptoms a little bit, but they don't really get to the root cause of any disease. 3 or 4 years ago, a drug was approved called aducanumab, or Aduhelm, and it was the first drug that is called disease modifying, in that it removes from the brain one of the proteins associated with Alzheimer's disease, called amyloid. That drug was so-so, that came and went, but since then 2 more drugs have been approved, one called Kisunla, one called Leqembi. Both of these are infusion drugs given every 2 or 4 weeks, and both of them remove from the brain this amyloid protein. They're only appropriate for people with Alzheimer's, not Lewy body, not Parkinson's, not anything other than Alzheimer's disease. And they don't cure anything. They don't halt the disease in the tracks, but they do, on average, slow the decline by about 25 or 35% or so. So many of us feel in the right population, they're not for everybody, but for the right people, once you're screened and proven and don't have any number of other medical problems, many of us will try to offer those drugs to patients when we can. We don't know how long the drugs should be taken. They may be necessary indefinitely. And so there are a lot of things we still don't know, but they are more hopeful than what we've had for a long time. And there are different versions of these drugs being looked at, looking at giving these drugs to people who have no symptoms yet, but right now they're only appropriate for people who have mild cognitive impairment and mild dementia, only due to Alzheimer's disease. There's one mic in.
How do we know when the time is right for an initial evaluation? If we're not having any of the symptoms like our fingers up won't go, how do we know?
Yeah, that's a good point. So I mean, the easier answer is if you're worried, talk to your primary care doctor. And that's the first person to talk to. Talk to your primary, let them know what your concerns are, see what they say. Now, I'd be more concerned if I'm not saying you, but you brought up, so I'll point to you anyway. If you don't know you have a problem and your family says something really is going on, then that would be certainly a time, if not sooner, to get some help. So once we, and hopefully not we here, but once one loses that awareness of having a cognitive problem, very oftentimes that means we're entering the stages of dementia. And I'm not talking about losing awareness because that's our personality or we're afraid to face something, but when we truly don't know there's a problem, I use the saying, we forget how forgetful we are. Once that seems clearly the case, then that definitely is a time to get some help. But really, if you're worried, you should talk to somebody. But talk to primary. There aren't enough neurologists out there to see everyone from day one. There's certainly not enough behavioral neurologists to see everyone who says, well, maybe I have a memory problem. You got to start with primary care. Let them do their thing. Make sure there's not depression or sleep problem or thyroid problems or stroke or any number of things that can also produce cognitive symptoms that you don't need a neurologist to figure out. We had some, yeah, there we go.
I guess I'm wondering how, let me see. I was taught children are close. I was taught children should be seen and not heard. I hate that line. And yet, as I age, I realize that lots of questions I might have asked as a child, I don't know how to ask today. It's not okay to talk. I wonder how that affects dementia.
Yeah, so I'm not entirely sure, sorry, what the question is. Can you maybe restate it a little if you don't mind?
I can try. If you don't learn how to talk or to ask questions or interact, then as you age, it doesn't become easier sometimes. In some ways it does because you learn along the way, but you miss some learning also.
Yeah. So, I mean, a couple of ways I might think about that. How do I start? Engagement is important. Social engagement is important, and at all ages. And sure, if one doesn't develop those skills, those abilities in younger years, they're probably not going to become a social butterfly at the age of, say, 75 or 80, for example. Or if there is a sudden personality change, then you wonder about some medical problem, maybe a stroke or a dementia causing a personality change. But I don't know. I encourage people to be active and engage with others, and that's why Debbie mentioned being here. We've got social engagements, physical engagements, and things that one can do to remain active. The brain's like a muscle; we have to use it or lose it.
Thank you.
Doctor, thank you for coming here and enlightening us. I always had a question, a concern about what is the difference between Alzheimer's and dementia?
Yeah, great question, and I probably answer that 1 or 2 times every day. So Alzheimer's is a disease, and dementia is a symptom. So as Debbie mentioned, dementia is an umbrella diagnosis. A lot of things cause dementia. Alzheimer's is just one of them. So when I see a patient, or maybe more so when a patient comes to me and they say, well, I've been diagnosed with dementia, then I say that's only half the answer. We've got that symptom, but we need to figure out now what's causing it. Was there a stroke? Was there a brain tumor? Is it Alzheimer's? Or commonly, are there several different things? So again, I consider mild cognitive impairment and dementia as symptoms, whereas Alzheimer's, Lewy body disease, Parkinson's are diseases.
I have 2 more questions, but let somebody else. I've lost it. must be one of those things.
That's a no finger sort of, well, that's okay.
I've read a couple of articles that suggest that statins are having some impact on memory loss. Is that something I should believe, or is that nonsense? Or do you know?
Yeah, so statins have been discussed for many years as a possible cause of dementia or confusion. And I have occasionally seen people who start a statin and get very confused, and they stop the statin and they get better. I think if you have that obvious cause and effect, I think there's something to it. But it really is very uncommon in my experience for there to be strong evidence that in individual patients, statins cause confusion. I think you have to go back to ask the doctor, why are we on a statin to begin with? Are we 50 and have a cholesterol through the roof? Well, that person probably needs a statin. But if there are any 95-year-olds in here, I apologize, but if we're 95 and the cholesterol isn't that big of a deal, then you probably don't need to be on a statin, because it actually takes a lot of people treated a number of years to prevent a single heart attack or a stroke. And don't quote me on the number, but it may be something like you got to treat 20 people for 5 years or something like that in order to prevent a single event. So that says that on an annual 1-year basis, the chance that you are preventing a heart attack or a stroke in that individual is really pretty low. So again, if someone's 50, you've got 20, 50, however many years to go, of year by year by year, I think it's one thing if your cholesterol is very high. But if you're quite a bit older and the cholesterol is not that big of a deal, you might not need it, not from a cognitive standpoint, just because it's not going to likely make a difference.
Excuse me, what is the relationship between heredity and Alzheimer's?
Yeah, great questions today. So Alzheimer's, risks for Alzheimer's, the number one risk is age. Regardless of genetics and everything else, the leading risk is age. But it seems to be a combination of age and lifestyle and genetics. And we don't know the formula, except that the older you are, the more likely one is to develop Alzheimer's. The strongest genetic risk is if your parent or sibling gets dementia from Alzheimer's before the age of, say, 50. And that does occasionally happen. And that happens in every generation. So grandparent's demented at 45. Parent is demented at 50. Sibling is having problems at 45. If it's that strong of a family tree, you'd worry about that. And there are tests that can be done to look for those particular genes. But those genes, in terms of the number of people who have Alzheimer's, is very, very uncommon. I've got probably one person that I'm following right now who has that sort of family and has that proven gene. There are other genes that we call risk factor genes, which means if you get one or two of the genes, it increases or decreases the risk, but it doesn't necessarily guarantee someone will get Alzheimer's. And those risk genes interact, again, with age and with blood pressure, cholesterol, diabetes, whatever, to modify when that disease will occur. There's a gene that can be tested called ApoE that we check in people who might be on these infusion drugs, but even that's a risk factor gene. It's the gene that people used to get through 23andMe, which I think now is bankrupt or getting sold off or something or other, so that's no longer an option. But so genetics, it's usually a risk rather than an actual direct cause.
If someone has a brief episode of minimal cognitive impairment, what is the indicated follow-up, and what are the odds that that will eventually progress to dementia?
So I personally wouldn't diagnose mild or minimal cognitive impairment if it's isolated. I only use those terms if it's a persistent problem. You can make anyone confused if you stress them hard enough.
But if they don't remember an episode a little brief period of their life that occurred, today or yesterday.
Yeah, so it's okay. So if there's someone who doesn't remember something that happened in their life, whenever that was, but if the only problem is they don't remember an episode that happened at some point It's hard to say. It may be nothing. If it's more than just a minute, there's a thing called transient global amnesia, where you were one. You can't make new memories, and that lasts for maybe a couple of hours or so. So TGA, or transient global amnesia. Yeah, if that happens, I would see a physician. Or if it's happening like actively happening right now, I go to the ER because you want to make sure it's not a stroke or something. Now, all the cases I've ever seen of that, I've never seen it obviously be caused by a stroke. Usually we don't know what causes that. But there's no sense in waiting 6 months to see a neurologist for that, because by 6 months, if something bad's going to happen, that would have happened way before then. So if it's happening right now, go to the ER.
Is there a correlation between dyslexia or ADD and dementia?
Yeah, I'm not aware of dyslexia. I don't think so. ADD, not that I would consider to be very strong. So no. Now, if you start having attention problems, it's say 70 or 80 or something, that's different. But if you have dyslexia or ADD or ADHD since childhood, which is really, what I would consider to be true dyslexia or ADHD, I'm not aware of any eventual risk for dementia.
UTIs in dementia, or cognitive impairment.
Yeah.
Both my parents have experienced that.
So that's what I thought we were talking about over there with the transient, very temporary confusion. So a UTI, or a urinary tract infection, very common, and very commonly will cause confusion in someone who's older. You don't have to obviously have dementia or MCI beforehand. Doesn't usually happen in younger people, but very commonly causes confusion in older people. And if you're demented already, it definitely will often make that worse. For reasons we don't fully understand, the confusion that happens during UTI doesn't always fully go away. It usually does. It may take a while. It depends on how bad thinking was to begin with. But it's probably a combination of what we call cytokines and chemicals and proteins that get released in the body as the body's fighting infection that cause confusion and may cause a little bit of injury to the brain. But I wouldn't assume that in the depth of confusion due to a UTI, I wouldn't assume that's where the person's going to stay. You would hope that you treat the infection, give them time to get better, and hopefully there will be significant improvement. So I wouldn't kind of fear the worst in those periods of confusion. I think they've got one.
I may have asked you this question before, but I can't remember if it was you. But I'm still intrigued by it, and it's based upon a study, and now there's a further dimension to it. So let me ask the question, see where you go with it. It has to do with how the brain functions. The study was showing that any language learned before 10 is stored in a part of the brain that has faster and easier recall. But any language learned after the age of 10 is stored in a different part of the brain that has slower recall. And of course now it's just a matter of being able to speak English. But how the linguistic capabilities and the confusion and trying to pull something back which eventually comes back is almost a neurological slowdown in the process. And I'm wondering, because they tell you one of the things you can do to help is learn another language. And we're in our 80s now. And it's possible, but to avoid confusion of languages and to be able to recall, it's just a fascinating subject for me.
Yeah.
There's a question there, so.
I'll kind of make up the question then. And I'm not a neurolinguist or really a neuroanatomist, but it is fascinating, the concept of language and dementia. Now, I've seen plenty of people who are bilingual who get demented. So it's not like knowing 2 languages even early on will definitively prevent getting the disease. But it may help delay the onset a little bit. It's also interesting seeing people who know 2 languages, how languages are lost as dementia progresses. And it's what's generally lost is a language that's used the least. I mean, sometimes you don't learn language when you're a child, but speak another language more as you get older. You get married, go to school, or whatever. And in those people, even though, say, the initial language they've known for their entire life, that one gets harder and harder and harder. And so, why that's the case, I don't know. The brain it's fascinating. It's a big group of networks and circuits, and we're still figuring out how all the circuits interact and work together. But I don't think I'm going to give you a very smart answer on that one, so I apologize. We've got a question up here.
How does profound deafness, how does profound deafness affect dementia and loss of cognition and loss of vocabulary?
Yeah, so hearing loss that's a very interesting subject with dementia, because there is evidence that hearing loss is a risk factor for dementia. And this next statement isn't quite as solid, but it's a probable, which is treating hearing loss probably will partially counteract the risk of dementia that you have from having hearing loss. Most of this is based on what we know about, as we get older, the age-related hearing loss. I don't know that we know so much about that subject in children who have hearing loss for their entire lives, or younger adults who become older and have hearing loss for, say, 60 or 70 years. But it does seem to be the case, and this is probably one of the most, I don't want to say preventable, because it's risky to say you can prevent dementia, but it's a risk factor that's probably the most underappreciated and has the most opportunity for making a difference across society, which is to address later life hearing loss through hearing aids or other sort of interventions. So it is a risk factor. Now, profound versus a little bit of hearing loss, I don't know if we know so much about that, but hearing loss in general is a risk factor for dementia.
There was something on the national news tonight, and you have to help me to set this up, because I've lost the name of the condition, but it is an acute dermatological condition that is related to chicken pox. Shingles, all right. Thank you. And there was something on the national news that said that researchers have found that those individuals who have taken the shingles vaccine have a lesser chance of getting dementia.
Yeah, so that's another interesting subject. Autopsy studies have often found particles of the herpes viruses, and shingles is in that herpes family. They have found evidence of that type of virus infection in the brains of people with Alzheimer's disease, more so than people who don't have Alzheimer's disease. So there does seem to be a risk of virus somehow playing a role in the disease. But it's important to sort of know, and so the Shingrix vaccine, I haven't seen that study, but that would support the theory that reactivation of that chickenpox virus would somehow get its way into the brain and maybe accelerate the rate of developing dementia. Plus, shingles is apparently just a super painful condition to get anyway. So I would encourage one to get the shingles vaccine. There's a lot we don't know. I don't think you can say you can prevent Alzheimer's disease by giving everyone the shingles vaccine. There are plenty of people who never have chickenpox who do get Alzheimer's disease, but that may be one of the risks that would be added to round 2 of one of the earlier slides up there.
Could you speak to ways to diagnose Alzheimer's other than symptomatically or upon autopsy?
Yeah, there's a wide spectrum between symptoms and autopsy. Usually it's based on symptoms, though. I mean, historically, that's what we did. Because historically, if you are a little bit off on the diagnosis, it didn't really make a big difference. But now we have a lot of tests that we can offer to try to narrow that down. So there are blood tests now that are pretty good at identifying if someone probably has Alzheimer's disease. Spinal taps are even better, measuring the amyloid and tau proteins. This is a different PET scan, but an amyloid PET scan is very useful to determine if someone has the Alzheimer's changes. The problem with some of these things, though, is that you can be 85 years old and have a positive amyloid PET scan or a positive spinal tap and never get Alzheimer's disease symptoms, because it takes 20, 30 years to get sick, and at 85, you may not have 20 or 30 years. So one does need to be cautious about who to do these tests on, because it really may not make a difference in the absence of symptoms. This is an FDG PET scan, which, as Debbie was alluding to, injected the person with radioactive sugar. And this isn't definitive for Alzheimer's, but the picture on the right has kind of blue signal on the lower edges on both sides, and that's a typical location for abnormal change in someone with Alzheimer's disease. So really I would say, and there's actually some debate about this, which is, do you diagnose Alzheimer's disease in someone who has no symptoms? And there are two camps in the medical field about, is that right or wrong? I would, until we have a medicine that is shown to be helpful in someone who has no symptoms yet, we call that pre-symptomatic disease, I will only do the workup right now in someone who has symptoms, because I'm only going to treat someone who has symptoms. But that may change in the next, say, 3 to 5 years or so. So it's blood tests, brain scans, and spinal taps. And cognitive testing, that's called neuropsychological testing. Those are all helpful. And I can, if this thing works, I can pass. You can have this mic. You can Deb, you can run twice as much if you want, and pass that one around too.
You keep asking, speaking about symptoms of Alzheimer's. Be more specific about what are the symptoms, just besides forgetfulness.
Yeah, so it often depends on one's age. If someone is 80 and up, almost always memory loss is the primary symptom of Alzheimer's disease. Short-term memory, I'm not talking about I can't remember where I went to college or where I was born or my birthday. Those things are pretty well fixed. But forgetting where to pay my bills, leaving the stove on, causing fire, a prominent, persistent, short-term memory problem is not only Alzheimer's disease, but that usually is the primary symptom of Alzheimer's in someone in the later years. Younger people, 30s, I mean that's pretty rare, but 40s, 50s, and even 60s often have what we call variants of Alzheimer's, or maybe a language form, or maybe a decision-making, we call that executive syndrome, or they may have a visual condition called PCA, where it starts in the back part of the brain and causes vision processing problems before anything else. But again, if one is 80 and up and short-term memory is really, really bad, the first thing I would think about is could this be Alzheimer's disease?
When people show sort of a mental diagnosis with dementia, say suspicion, maybe some paranoia, or outbursts of kind, that's not their usual personality. Do you treat those symptoms as a neurologist?
Yeah, I'm glad you added the last part as a neurologist. So it depends on what's the diagnosis and how bad are the symptoms. I don't think that someone whose primary problem is paranoia, for example, and they've been perfectly fine and suddenly they're paranoid that someone's spying on them, or they have delusion that Elon Musk is in love with them, or he's a lot of kids, so that actually might be possible, but something that clearly is not valid. If it's a psychosis of some sort, and that's it, I think those sort of patients are better suited by seeing a psychiatrist, a geriatric psychiatrist. Yeah.
What about depression that you might see with dementia?
Yeah.
You
So
know, where they're not doing the activities that they love, and you're still seeing these signs.
So it should be treated. Depression is usually very treatable. And so I would encourage aggressive treatment of someone who is depressed, whether they have anything else going on or not. But so it kind of depends on that particular person, who their medical team is at that time. I wouldn't encourage a primary care doctor to refer someone who may have dementia, but that's been straightforward, who happens to also now get depressed. I don't see really a need to see a neurologist for that. Number one, primary care prescribes more antidepressants than any neurologist does, just because they see more people. Number two, if they're going to send to somebody, send them to a psychiatrist where they do mood symptoms like all day, every day. I think where when I might treat someone who has depression or anxiety is if I'm seeing them and they're coming to see me primarily for cognitive problems, and they also happen to have some mood sort of symptoms, I might treat those. But if the mood symptoms are really out of control, then I might send them to a psychiatrist, or encourage before they see me, they see a psychiatrist. Because really, if someone their thinking is so disjointed that they're super paranoid that someone's out to get them, I really can't do my job, because I can't assess someone's memory if they think I'm the spy or I'm doing whatever they think is happening to them. So they need to for me to help, they need to get the symptoms under control. And that's going to happen fastest with the psychiatrist. And I would say there are more psychiatrists in town. I don't know the numbers. There are more psychiatrists in town for the geriatric population than there are behavioral neurologists. I'm confident with that.
Have you seen, or do you anticipate a role for artificial intelligence in the future of diagnosis or treatment?
Yeah, that's a great question, and I have mixed feelings about that because I do want a job, but I don't think that AI is going to take away. I don't think I'm going to lose my job to a computer. Enhancing maybe, and I think where it might be helpful would be in the screening process. There's evidence that certain speech patterns might be an early sign of dementia. Well, let the computer listen to the speech pattern and measure that and evaluate that. That's very time consuming, and it can get a lot of data. And there's no way a human would or could or would want to do that. I think that would be an example of how AI might facilitate the process significantly. They're using AI in some imaging studies now to do an overread of the radiologist to look for subtle changes that might identify early symptoms, or not symptoms, but early changes associated with more and more types of dementias. But I think we're a very long ways to go before and the computer could probably even put together a PET scan result, spinal fluid, and you plug in some cognitive symptoms, and I think the computer can do a decent job in at least suggesting what might be going on. But I think we're a long ways to go before the computer can replace the human. And also, and this is a very cynical thing to say, but lawyers can sue a doctor a lot more easily than they can sue the computer. And so having the doctor there and I think it's very uncommon for doctors to get sued for missing diagnosis of dementia, but I think there are social reasons that physicians will have a role indefinitely. But yeah, it'll help.
Can you please address the relationship between Parkinson's disease and dementia?
Yeah, great question. So people who have Parkinson's disease long enough will usually get dementia of some sort, but it's a different type of dementia than Alzheimer's disease, and it usually progresses a lot more slowly. I've never examined the guy, but Michael J. Fox is still alive, and he started having symptoms, I don't know, like 40 years ago or something. And I think he still has interviews and things. And so he may have some dementia right now, but I mean, for 40 years of a neurological disease, that's still pretty good. The dementia, so the dementia people with Parkinson's get, it usually progresses more slowly. It's usually 10 or more years after the physical symptoms develop. And there's more of a slowness of thinking than a true memory loss. There is often a visual processing problem more than a language problem. So cognitive testing or a careful history can sort of tease that out. But if someone's got Parkinson's for 20 years, I mean, that's no secret to anybody. And so it's often pretty clear, is the dementia to Parkinson's disease, because they had Parkinson's for a long time. Now people can get Alzheimer's on top of Parkinson's dementia, and things get a little messy in that situation. But yeah, Parkinson's cognitive symptoms are very common, but it's not usually a problem until many years into it. Not dyslexia, I hope.
When you were covering statins and medicine, I didn't hear you mention Prevagen, and there's a really strong selling campaign out about Prevagen, and I don't know what the positive sides are, the downsides, or if it's been analyzed. I'm just curious.
Yeah, if we have Google on this, I would show you. I would just Google FDA and Prevagen and see what it says. They've gotten in trouble for making claims they shouldn't make. So cynics would say, and some very smart cynics would say, that Prevagen gives you expensive urine, but that may be about it. Now, if you have a vitamin deficiency, that's one thing. If you've proven you've got a low B12 or low D or something, sure, treat that. But is there something unique or special about Prevagen? I don't think it's been proven. Or any other of these vitamins that are being sold. And my grandfather bought tons of those, and so I know these marketers are very, very skilled and very good. But I don't recommend any of those supplements unless there's a true deficiency.
Are there any drugs that maybe we should avoid? Prescription medications?
Yeah, so it's hard for me to say avoid a prescription because presumably that doctor is giving that prescription for a good reason. It's easier to say what over-the-counter medicines to avoid, and the big one is Benadryl. Benadryl or diphenhydramine. It's anticholinergic, and that blocks the benefit of things like Aricept and Exelon. No, I've never seen anyone look super demented from Benadryl and they get better after you stop the Benadryl, but it is associated with the risk of confusion, and some articles would suggest a risk of dementia too. The prescriptions that I'm not a fan of, and again, I'm not going to walk in there and unilaterally discontinue someone's medicines coming from another doctor, but I don't really like things like Valium or Klonopin. These are called benzodiazepines because they can be very sedating, and there's often a role for them, but they're like chemical forms of alcohol, and they don't do wonders for thinking in general. Now, there are some people who need them because the anxiety is so bad and they can tolerate it, and it's better to have a risk of having some dementia than to live with horrible anxiety. But if one can get off of benzodiazepines, I would definitely hope for that to happen. Some of the antipsychotics, and I prescribe some antipsychotics, but some of them can be associated with cognitive problems too. So it really depends on weighing the reason why someone's on it, and the risk of being on that medicine, and you see cause and effect. Do you hear from the family, they start the medicine, they get real confused. Stop the medicine, they get a lot better. And sometimes with careful history taking, we are able to get that sort of obvious cause and effect.
Is Aricept still used sometimes?
Aricept is used a lot. The Aricept or donepezil, that came out, I think, in 1996 or something, before I was a physician. And it's the nice thing about Aricept, it's easy, it's safe, it's once a day, and it's better than nothing for someone who has dementia. So
My mother had some in her final years, but dementia finished her pretty fast, but and one of the earliest symptoms was when she was wandering around the house suddenly, not apparent, and then she ended up driving out to another town that she wasn't even supposed to, and I knew something wasn't right.
Yeah, that's not right. Yeah. So Aricept, I prescribe Aricept all the time. It's not gonna fix anything, but again, it's better than nothing. And you can use Aricept with just about anything else. It doesn't really have any interactions with any other drugs.
We have one other question about anesthesia and the effect on the brain.
Yeah, that's a tough one. Again, because if you need anesthesia because you need a surgery, then you sort of have to suck it up and bite the bullet. But if one does need anesthesia, I would encourage them to talk to the anesthesiologist, who's the one to give it. And especially if there's a memory problem to begin with, ask for the lowest amount, ask for a drug that might have the least effect on the brain. And there are anesthetics that have varying degrees of activity within the brain. And if the surgery can be done with anesthesia, without it at all, with what we call conscious sedation, then that might be even better. But you don't want someone waking up in the middle of a surgery. You don't want someone who has dementia realizing in the middle of a surgery their knee's getting cut open. And so I think the priority is get through the surgery safely without someone waking up. But yeah, if you can use the lightest, the safest medicine, I would encourage that.
Anyone else? Thank you so much.
Thank you. Thank you.
Really appreciate it.